myself, I'm oncologist, and I'm very interested in integrative oncology and all kind of, innovations and whatever out there is worth applying to our patients. So, but not really only about oncology, all kind of probably chronic type of illnesses. I have worked with ozone therapy, all kind of, these type of more natural ways of, helping people, not just doing some kind of, because by nature I'm purely chemotherapist, yes, but I have moved away a bit from this only classical approach. So I'm very open to innovations. This is why I'm here, if it helps you.
Yes, that's very helpful. Thank you, Linda. You're in the perfect place. And I invite you and other attendees that if this is your first time, to type into the chat your email contact, and that way we can make sure that you're invited in the future. Eric, can you say a few words about where you're calling in from? Eric Scheinbart. Let me see. I may have. Let me see.
Eric.
Thank you, Eric.
Eric. Let me see if Eric's is here.
There he is. Let me. Okay, I'm clicking the unmute. You may have to unmute yourself, Eric.
Unmute. How's that?
Beautiful.
Can you hear me now?
Yes, we can. Thank you.
Great, great. Well, thanks for the invite. I'm from the United States. I'm in Atlanta, Georgia right now. I'm an MD. I do alternative medicine and integrative medicine for cancer and chronic disease with all naturopathic natural plant treatments, no pharmacoletics. I've been doing this for 20 years with excellent results. So I'm happy to hear what you have to add to, and I can contribute from.
Wonderful. Thank you so much. And Ahmed Abu Halala, could you, Ahmed, could you unmute yourself and give us a couple of sentences on where you're calling in from?
Yes, this is Ahmed, last name Abu Halal. I'm calling from Calgary, Alberta. We have -10 right now, a little bit freezing cold. So I enjoyed this session to learn more about the pain management. I'm a family doctor, and I'm interested in pain and pain management, and I have lots of patients with chronic pain.
Beautiful. I'm sure that you'll get something useful out of today's talk. And
yeah.
then Isam, and also someone who's on a Galaxy S10. We'd like to hear from you as well. So Isam, let me see if I can unmute you. Give me one quick second. Yes. Let's see. Where are you, Isam?
Isam is my brother.
Yeah, I'm here. Thank you very much for this opportunity. So I'm Isam Khayyat. I'm a pain specialist in the Northern Virginia area. So I have a background in the academia. I used to be an associate professor in the anesthesiology and pain medicine in UMass Memorial Medical Center in Massachusetts. I moved to Northern Virginia in 2016. Since then, I've been having interest in regenerative medicine and PRP and all this new innovation. And I met Dr. Abu Halasa through LinkedIn last week, and I'm still interested in this field to learn and network with this group of people. Thank you.
Beautiful, beautiful.
Thank you for coming.
We have, just want to get everyone, Michael and Khalud and Kathleen. We'd like to, I'm not sure if we're going to have enough time to get an introduction from all of you, but if you all could type in your email address into the chat, we will make sure that you get an appropriate introduction in the future. I don't want to hold up Dr. Halasa, and Asim, keep him honest today. He's going to talk over everyone's head. So you're
right. So you need to monitor me here because you're pain management. Well, I'm a pain management too, but you know, we're going to butt head here. But I want your feedback because your feedback is very critical and important, especially when we're talking about neurogenic pain. So let's go and today definitely we're going to talk about neurogenic pain, centralized pain versus peripheral pain, and let's get here. And let me give you the host thing first, so I can be making sure that did you get the host? No, make you a host. Okay, so now you are the host. So make sure that you invite the people to come. Do you see the slide? Can you see the slide?
Yes.
Okay, good, good. So yes, the first company that I'm working with is Nitro Medicine. I'm the founder of Nitro Medicine. And my name is Dr. Halasa. I'm a pain management specialist. I did practice pain management for a couple of years in Delaware, and we've seen a lot of patients there. You can say thousands. We have a very big clinic. It was compassionate pain management in 3 areas, in Dover and Rehoboth. And we saw a lot of patients. And all of them, most of them, they have problem with narcotics and addictions. And that's the reason I start thinking about how we can wean patients from narcotics and looking for other alternative, because we find out this narcotics is actually making their pain even worse. I mean, yes, you can numb the pain in the beginning, they feel good, but the problem is that they will be seeking more of these drugs, and we're going to explain why those patients are seeking more of drugs, which we call the drug addiction, in the coming slides. And it has to do that narcotics does induce oxidative stress in the brain, and oxidative stress leads to neuroplastic changes, and also it leads to insensitivity of the neuroreceptors. And so if the neuroreceptors are insensitive, then the patient needs more drug to hyperpolarize the neurons and numb them, and that leads to all the problem we have, which is the addiction and all the psychological problems that comes along with neuroplastic changes. So let's first understand the difference between central pain and peripheral pain. And the problem that we have in pain management is that most of the doctors, they are focusing more on managing the peripheral pain. So when the patient's complaining about their pain, the doctor will focus on the site of the pain and start injecting all the site of the pain with steroids and all the medication that we know, PRP. And some of the patients, they benefit from it, but other patients, they don't see much of response. And the reason, because pain is not just peripheral pain, there's also central pain. And the central pain can evolve from the peripheral pain, from chronic peripheral pain. And so we will see all these doctors are shooting into, for example, if they have a knee problem, or they are shooting all this injection in the knee, and still the patients are not improving. And the doctor will start wondering, I did everything I can, but the patient is not responding. And the reason, because that pain is not coming from his knee joint, it's actually coming from his brain. And that kind of pain, we call it central pain. And it's a neuropathic pain that happens when the central nervous system does not process the pain signal properly due to the neuroplastic changes that's happening from the chronic peripheral pain. Peripheral pain is being defined as nociceptive pain that is not part of the nervous system. So peripheral pain is due to inflammation or injury of the tissue, of the peripheral tissue, and that irritate the nociceptive neurons and gives you what we call the peripheral pain. And yes, all this injection that we're doing, the PRP, anti-inflammatory drugs, it may work with nociceptive pain, but when it comes into central pain, we really need to target the brain as the spinal cord and manage the source of the pain, which is not from the peripheral area. It's actually coming from the brain due to neuroplastic change from the chronic peripheral pain as it evolved into central pain. And that's what we're going to see in the coming slides, how the peripheral pain evolve into central pain. And so because of that, about 20% of the patient with osteoarthritis who have had their knee or hip replaced continue to have chronic pain, although there's no really more joint there. So that means the pain is not coming from the joint. The pain has likely become centralized. The pain is coming from the brain itself and the spinal cord due to neuroplastic changes. So it's not caused by the inflammation or injury. There's no really any inflammation or injury. It's a knee replacement. And pain doctors will argue, well, it could be because of neuroma. And so they start doing those radio frequency ablations and start burning out this nerve, and still the patient has the pain. So it's not peripheral neuroma. It is more of pain due to neuroplastic change, especially from the amygdala and from the spinal cord. And that's what we're going to see, how the peripheral pain evolved into central pain. But let's go ahead and just have a general look on how the body processes the pain signals. So let's say if it happened that accidentally you got torched with a candle, with the fire of the candle here, what will happen? This pain signal will go up into the ascending spinal thalamic tract. Of course, it goes to the peripheral neurons here, nociceptive neuron, and then it goes up where to the thalamus. Once it gets to the thalamus, that the patient starts feeling the pain. But in order for patients to feel the severity of the pain, that signal has to go to the amygdala, as you see it here, which is the yellow color here. See the signal goes to the amygdala, okay? See that? Okay, and that's where the patients start feeling the severity of the pain. That's why we ask the patient, your pain from 1 to 10, can you scale, can you grade it? And they say, well, I have 5 or 6 or 7. When the pain signal reaches the amygdala, that's where the patient can grade the pain and tell you exactly how severe the pain. And so the amygdala is responsible for pain modulation and also gives you the severity and process the pain signal, as we're going to see here. Then what will happen to this pain signal? It will go to the hypothalamus, as you see it here. And when it gets to the hypothalamus, you get the fight reaction. Sympathetic activities will go up, and it gives you that fight reaction, and the patient will start withdrawing his hand. Of course, that can happen also on the spinal cord level withdrawal, but the patient will respond to that by fight reaction, which is part of it. You will, we know the signs and symptoms of fight reactions: breathing fast and turning your head into the site of the injury, and all the warning signs. Heart rate will increase. That's because of the autonomic nervous system response to sympathetic activities, right? And gives you all this pain behavior, I don't think with this little fire that patient will be crying, because it's not that painful. But you can feel the pain, you can see the reaction of the face that the patient is experiencing pain. All of that is coming from the hypothalamus. Then what will happen is that the pain needs to be localized. Of course, this is the job of the primary somatosensory neurons. As you see that the signals goes up to the primary sensory somatic sensory cortex. And that's where the patient can localize the pain. So the doctor will be asking the patient, so where is your pain? My pain is, in my hand. And that happened when the signal reached to the somatosensory cortex. And then what will happen here, the signal will go to the secondary area, right? Sensory area, the secondary one, or the sensory association area. And what would happen, the patient will be able to even qualify the pain. Say this pain is coming, it's coming from the fire, it's burning pain, so he can identify the kind of the pain or the quality of the pain. And then what will happen is the signal of this experience, all this experience as a pain signals and all the other inputs that's coming from the vision and from the sound and all those sensations, they will be all linked together, and they will be all stored, all this experience itself, in the hippocampus. So the hippocampus is like the hard drive. And so all the experience of the patient, of the pain, will be stored into the hippocampus, as you see it here. And then they will be sending the signal, of course, to the amygdala. amygdala will process the pain, as we know, and then also it will be sent to the prefrontal cortex, and that's where amygdala and hippocampus and prefrontal cortex, they will be assessing the pain, and they will give the patient the assessment the patient needs to know this pain. Is it a severe pain or is it trivial pain? If the pain is trivial, what would happen? Your frontal cortex, along with the memory of the past experience of the similar pain, will start activating. The prefrontal cortex will be activated, and they will start inhibitory signal to, as you see it here, to the amygdala and suppress that pain signals. And what does that mean? That the patients will be reacting less to the pain. So it's kind of cognitive control of your response of the pain. So let's say if this is what I experienced now, I put a little torch in my hand, my memories about this experience will tell me that this pain is a trivial pain, don't worry. So your cognitive will be able to control the behavior of the pain and prevent all this dramatic pain response, right? Because the pain is not that big deal. And so what would happen? The prefrontal cortex will start inhibitory signals and dump that pain signal, and that will prevent all this dramatic response of the patient to the pain that we know if the patient experienced severe pain. And that's what we're going to see in the coming slide. So what will happen if the patient is being torched with the fire, or I put my hand in a very hot stove? That's a different scenario now. Now I have huge pain signals, a massive one that will go up to the thalamus and give you the sensory of the pain that we know. And then it goes to the amygdala, where we can process the severity of the pain, right? And then it goes to the hypothalamus, and that's where it gives us what the reaction of the pain, the fight, flight reactions, and all the reaction of the pain that we know. It's starting from the hypothalamus. And of course, the pain will be localized. I'm going to pain signal to the somatosensory cortex, and then it goes to the sensory association cortex, and that where the patient can recognize this is a burning pain. And then the signal will go to the hippocampus. And here, the patient will be able to assess the threat of the pain based on the past memory. If the patient has a past memory of burn before, then what will happen? The whole reaction will be very big for the pain, and you will see what will happen to those patients. Of course, they will respond to this pain, this massive pain, this severe pain, by crying, by, of course, they will be turning their head into the site of the injury. They will be doing all this dramatic pain reactions that we know. And can the cognitive able to control the pain? Can I control the pain with my prefrontal cortex? I doubt it, because the pain is so severe, and we have a history of the same experience. So what will happen is that, you know, your amygdala and your hippocampus will be sending signals to the prefrontal cortex, and the prefrontal cortex will, you know, try to suppress the pain signal as much as you can. Because if I experience this pain currently, I will try not to cry in front of you. I'll try to not to embarrass myself. So how that control, where that control comes from, it comes from the prefrontal cortex. So, but I'm being bombarded by the pain, massive pain signals that's coming from the hippocampus is telling me that this is a severe pain. This pain is we have it before. You will not sleep at night. It's very severe. It will last long. So all these memories will aggravate the pain signal, and your prefrontal cortex will be unable to really control the pain. Although they try, they send inhibitory signals, but what would happen, the amygdala will respond back and inhibit the prefrontal cortex, which means that I will be crying in front and I will let it go. I cannot really handle my reaction to the pain. So I'll be screaming, crying, and all the manifestation that the patient is suffering from pain will be, presented. And you would have all this flight-fight reactions as well, the tachycardia, breathing fast, also holding breath. I'll be holding my breath as well. And why I'm going to hold my breath, we're going to talk about it in the coming slides, because that helps me to suppress the pain signal. We're going to talk about it, and we're going to see that in the animation. Okay, so yes, so what would happen here? Your hypothalamus, what would happen? We said that one of the things that I'm going to do is that when I have severe pain, when I put my hand on the stove, besides all the crying and all the reaction of the pain that we are doing when we have massive pain or when we burn ourselves, right? And yes, we're trying to not to cry, not to embarrass ourselves, and we're using our prefrontal cortex, but it's something, this is massive pain, we cannot, so we start crying and screaming and seeking medical attention, right? But one of the things that we do commonly is that we hold our breath, like, and we perform what we call the Valsalva maneuver. And why are we doing that when we have a massive pain? Why we start holding breath like this and squeeze ourselves and perform Valsalva maneuver? Because Valsalva maneuver can give us some sort of analgesic effect. Because what happened when you do Valsalva maneuver, you would have transient increase in blood pressure, and that blood pressure will stimulate the bioreceptors of the carotid blood vessels. What will happen when you stimulate the carotid blood vessels, of the carotid receptor, bioreceptors of the carotid blood vessels? The signal will go to solitary nucleus in the midbrain, and the solitary nucleus will start stimulating this two descending neuron that's coming from periaqueductal gray, and also it's coming from the rostral ventrolateral medulla. And those neurons, they will be secreting norepinephrine, and they will be secreting serotonin. And when they secrete norepinephrine, as you see it here, see how they are stimulating this two descending neuron, which is serotoninogenic and norepinephrinergic, which is the rostral ventrolateral medulla and locus coeruleus, and also periaqueductal gray. All of this will be stimulated, and what would happen here? This will cause stimulation of the spinal cord interneuron. It's the encapsulogenic neuron. Did you see that encapsulogenic neuron, the black one here? What would happen? This will release endorphins. And what would happen to the endorphins? What is being released? They will cause a break in the sending pain signal. Did you see that? Okay, so that will inhibit the pain signals that's coming up. So that gives the patient what? A break, analgesic effect, and a decrease in the pain signals, and a relief of the pain. So this is one of the mechanisms that how we can internally stimulate the endorphins, and that helps us because it gives us that analgesic effect that we need to suppress the pain as we see it here. Okay, so what will happen here? We're going to see how the chronic pain, peripheral pain, evolve into central pain. Of course, this is a massive burning. It could be second or third or fourth degree of burn. And so it's going to be chronic pain. Pain is going to last for weeks, possibly months, right? This is big pain. It's coming from second, third, fourth degree of pain. And what would happen here? You would have chronic pain here. Pain signal will start bombarding the spinal cord as you see it here, right? And what would happen here? Who's going to carry those pain signal? Of course, the C fibers. And when the signals reach the C fibers in the spinal cord and dorsal horn, what will happen here? They release glutamate. Glutamate will open up the calcium channel, the yellow dots there. And what will happen to those yellow calcium channel? They will stimulate the NOx enzyme, generate free radicals. And that free radicals will lead to expression of structural and functional protein of the dendrites. So what would happen? You will have a spurt of dendrites that will be connected to the C fibers. Did you see that? Okay, so now I have, this is what is called what? Progressive neuroplastic changes. I am increasing the connection between the peripheral central neuron and the peripheral central neuron, right? And the ascending neurons. So what will happen when you increase the connections in the spinal cord? You're increasing the connection, the synapses between the nociceptive neurons, the peripheral nociceptive, and the ascending spinal thalamic neurons. As you see it here. Then this increase in the synapses, increase the connections, will lower the threshold. And when we have this lowering of the threshold of the pain, we will have something, we call it what? Primary hypergesia. So what is primary hypergesia? Primary hypergesia is that when I touch the area of the pain, just touching, not pressing, or you can say I'm pressing the area of the pain more than touching, what will happen? You will have a lot of pain. This is called what? Primary hyperalgesia. You can see it here. When I press on the side of the injury, right? Normally, we know we don't have that, but because of the neuroplastic change that happened, just a little touch like this, it can lead to pain, and this is called what? Primary hyperalgesia. Okay, now what happened again because of this bombarding of the dorsal horn with a lot of those massive pain signals? Because of this is occurring the chronic pain. See how we are now evolving the peripheral pain into centralized pain due to this progressive neuroplastic changes that's happening, right, in the spinal cord. We will also have secondary hypergesia. Let's go ahead and see that secondary hypergesia, how it's being developed. So same thing, we will be opening up the calcium channels by the glutamate that's being released, right, those neurotransmitters, activating NOX enzyme, stimulating the gene to express dendrites. More dendrites will be formed. Let me see here, the text here. Okay, that's fine. 518 is good. So what would happen here? We would have more dendrites will be formed, right? And they will be connected to the pain nociceptive neurons that is not coming from the side of the injury, but it's coming from the area around the side of the injury. So let's say this is the side of the injury, right? So when I press here, this is primary hypergesia, okay? But because of this chronic pain, which led to just neuroplastic changes and more connection between nociceptive, peripheral nociceptive and the central ascending neurons, pain neuron, right? Or spinal thalamic neurons, more connections there. And those dendrites will be connecting to the pain neurons that is not coming from the site of the injury, but from the surrounding healthy tissues. So what would happen when I press, although this is the injury here in my, and let's say my palm here, when I press into my finger here, which is away from the site of the injury, I will feel the pain. So this is called what? Secondary hyperalgesia. Did you see that? Okay. And this is due to this progressive neuroplastic changes that's happening and this growth of the dendrites and those new connections that we see here. Okay. What other things we can see here? You know, the pain signal will continue bombarding the spinal cord, right? And stimulating the central neuron to develop more dendrites that will be connected to the sensory, the touch neuron, the tactile neuron. See, this is an A, B, and B beta fibers. Those are tactile neurons, right? The A beta here, and those are carrying what? Touch signals, not pain, but touch. So when you touch your hand, the A beta neurons are responsible to carry those touch feelings. We call them tactile neurons. And see what will happen here. Dendrites will be formed because of this progressive neuroplastic changes here, and they will connect to the upcoming tactile neurons. So what would happen when your central neuron is connected to the peripheral tactile neuron, touch neurons? When you just touch the hand like this, just touching it, right? You will feel the pain. What do we call that? Allodynia. right? Okay. Okay. Can you mute, please? I'm hearing sound coming from the mute receptor. Dr. Tom. So here we see that it's very clear that we have progressive neuroplastic changes that's connecting to the nociceptive neurons and also to the tactile neurons and giving you this. I mute all the participants. Can you hear me, guys? Okay. Yeah. So we can see that the progressive neuroplastic changes where dendrites is being formed and synapses, new synapses being formed that will lead to secondary and primary hyperexia and also allodynia, as you see it here. In addition to that, this continue bombarding the dorsal horn with pain signals. It will eventually lead to release of those free radicals. Even with those free radicals that's being generated from NOx enzyme, those free radicals will escape outside the cell of the central neuron here, and they can reach and irritate the glia neurons. So what we have here, we have gliosis, right? And gliosis inflammation. So this is neuroinflammation here. And then what would happen to those glia cells when they're inflamed? They release free radicals. And those free radicals, they can cause regressive neuroplastic changes. You can see it here. See that? Regressive neuroplastic and the descending neurons, which is the interneurons of the encaphalogenic neurons. So what will happen when you are regressively neuroplastic changes? You're decreasing the dendritic connection between the encaphalogenic neurons and those ascending neurons here. Then this will increase and cause hyperexia, right? It will lead to more pain. It will lead to hyperexia and aggravate the hyperexia and allodynia, right? Because you are kind of decreasing the brake on those ascending pain signals by the regressive neuroplastic changes in the encaphalogenic neurons here, right? Also, those free radicals, too much of the inflammation, too much of free radicals can cause opening of the calcium channel, which is the glutamate receptors. Spontaneously, they will open. What will happen when you open those calcium channel? You'll have what we call the spontaneous firing of pain signals, even without any external stimulus. I don't have any leather or anything like that, and the patient start feeling the pain, shooting the pain, and that pain is not coming from touching or of the area of the injury. It's continuously coming from the spinal cord, and sometimes we call this pain as phantom pain, where because of this neuroplastic changes and the neuroinflammation, the neurons is firing spontaneously, and the calcium channels is being opened spontaneously, as you see it here. And this is called phantom pain. We experience the phantom pain, especially when the patient has his limb amputated, and still the patient feels that pain comes from the limb. I still hear his voice, Dr. Tom. Is there any way that you can mute that? So the scanner is operating appropriately. Thank you. Okay, good. So let's go ahead and move forward. And we see here that we explained the neuroplastic changes that's happening in the spinal cord that led to hyperexia and allodynia, and it led to spontaneous firing. It can lead to phantom pain as well. We're going to see very important pathway that explain the neurogenic inflammation, which is something it's very, very important. Neurogenic inflammation, and you know, this neurogenic inflammation, it is actually complicate almost all chronic disease out there. So this experience that I have with burning and chronic inflammation of the peripheral, it can be also something else. You may have injury in the bladder or infection in the bladder that evolve into centralized pain. It will follow the same pathway of the burning pain. and what we call it eventually complex regional pain syndrome, if we end up with allodynia and hypergesia, and that's the disease that's coming up from evolving of the peripheral pain to central pain, and all this manifestation of analgesia, hypergesia, and allodynia. That is the complex regional pain syndrome mechanism. But other diseases can follow the same path. Let's say if we have inflammatory of the bladder, UTI, and from UTI, an inflammation, possibly it's a chronic inflammation of the UTI, that inflammation can evolve into centralized pain, same way that we're having here, okay? And then we're going to see more about a neurogenic inflammation in the coming slides and the mechanism behind it. Same thing in migraine, it can follow the same path. And then you have what we call centralized pain, in addition to neurogenic inflammation, which we're going to see it in front of our eyes, how the neurogenic inflammation evolved from sympathetic overactivities. Other chronic conditions that we can know, colitis, irritable bowel syndrome, interstitial cystitis, all of this can follow the same path of mechanism and evolve into centralized pain and neurogenic inflammation. So let's go ahead and see more about the mechanism of neurogenic inflammation in this condition, which is, we can see it's now evolving into complex regional pain syndrome. And let's go ahead and see the pain signal is still bombarding. Okay, so let's go ahead here. All right. So that's the pain signal goes here to the peripheral, now the central, as you see it here, goes all the way up, okay, to the thalamus, as you see it here, and then to the amygdala, and then to the hypothalamus. Now, this is very important step. From the hypothalamus, what would happen? You would have sympathetic activities, right, as a response of fight-flight reaction, but too much of fight-flight reaction, too much overactivity of sympathetic because of this chronic pain signals. What would happen? You would have overactive sympathetic. You see that? I'm going to show it again. See, this is the activation of sympathetic, and this is overactivation of sympathetic. This is constant activation of sympathetic due to this chronic pain, right? So what will happen here? I will have overactivity of sympathetic fibers, especially the one that goes to the hand, right? And what would happen when you have sympathetic overactivity and releasing all this norepinephrines? Norepinephrine, what it does in the blood vessels, it opens up the blood vessels, so you have vasodilation. As that's what's happening in complex regional pain syndrome. You would have vasomotor instability and vasodilation, hyperemia, right? But also, the norepinephrine can stimulate the NOx enzymes in the peripheral tissue, and NOx enzymes generate free radicals, and free radicals induce inflammation and activate the immune cells, the white blood cells and all the immune cells, and it can lead to inflammation. And that's the neurogenic inflammation, right? From the norepinephrine that's being released, stimulating NOx enzymes, generating free radicals. And the inflammation can lead to what? Also vasodilation. It can lead to opening up the blood vessels and the capillaries and lead to edema. Norepinephrine can cause what? Vasoconstriction. So you will see area of vasoconstriction due to norepinephrine effect on the blood vessels, and then due to stimulation of NOx enzyme generating free radicals, and the free radicals lead to stimulation of white blood cells, you will see what? Inflammation. And that inflammation can open up the blood vessels and cause what? Edema. That is neurogenic inflammation. So neurogenic inflammation mediated by sympathetic overactivity. Did you see now the whole mechanism here? All right. So this is neurogenic inflammation. It's coming from the neurons. So the neurons, they're not just giving you that response of fight-flight reaction, the sympathetic part of the autonomic nervous system, but also it's part of the fencing mechanism. It stimulates the white blood cells, it induces inflammation, and why? to actually defend your body against the invasion or the pathogens. So this is called what we call neuroimmunology, right? So your neurology of your nervous system is not just feeling, sensation, and autonomic nervous response. It's a fight-flight reaction. It's also involved in activation of the immune system to mount against the invaders or to mount against the injury and the infection if there's an infection. So here we see that sympathetic is blindly opening up and inducing inflammation. Is this something physiological? No, it's not. This is now pathological because this is overactivity sympathetic that I don't need, but this is how the body is, and this will evolve into what we call the complex regional pain syndrome. In addition to that, and this is part of mechanism of neurogenic inflammation. In addition to that, the sensory neurons, which is the axons of ends of the sensory neurons and the receptors where they feel the pain, those C fibers at the peripheral tissue. We know they release glutamate and substance P to activate the sending neuron, right, at the at the junction in the spinal cord. But in the synapses here, right? But also there is some backfiring where those substance P and other neuropeptides, inflammatory neuropeptides, will be released from the ends of the sensory neurons here. And they can activate the white blood cells and induce inflammation. That is neurogenic inflammation. So the sensory neurons, the C fibers, their function is not just give you the feeling of pain and give you the warning that there's some injury there, right? Letting your body feels it and respond to it by withdrawing your hand or fight-flight reactions that we know, but also your neurons is part of the immune defense because they stimulate the immune cells because those substance P and neuropeptides, where there's receptors on those white blood cells, especially the macrophage type 1, and they will activate them and they induce inflammation. And this is called the neurogenic inflammation. So there's two parts of neurogenic inflammation coming from the sympathetic neurons releasing norepinephrine, which stimulates the white blood cells and induce inflammation. And also it's coming from the sensory neuron, the C fibers. They release substance P and neuropeptides, which stimulates the white blood cells and produce inflammation. This is the neurogenic inflammation. This pathway we talked about can be replicated the same way when the patient has neurogenic bladder or interstitial cystitis. The same pathway of complex region pain syndrome, this we talked about. So the interstitial cystitis, it's neurogenic inflammation. In addition to, we have the neuroplastic changes, what we talked about, and overactivity of sympathetic activities, right? And this pain signals that's aggravated by the neuroplastic changes, right? And this continuous firing. That's the mechanism of interstitial cystitis and neurogenic bladder. That's the mechanism of the migraine. Migraine is also neurogenic inflammation too. Rheumatoid arthritis, in addition to the autoimmune inflammation, maybe because there is antigen in the joints where your immune system recognizes it abnormally because of genetic error as a foreign, and you start having this mounted immune response, which is autoimmune, self-destruction. This can be complicated with neurogenic inflammation and central pain. Fibromyalgia, the same thing. It's a form of neurogenic inflammation. Okay? What are the conditions that we can think about? Any chronic inflammation in the body can progress and become also neurogenic inflammation. And this is what the mainstream medicine, they fail to manage chronic disease, partially because of unrecognition of neurogenic pain. Because how we manage by mainstream neurogenic bladder, they give them anticholinergic. What anticholinergic will do? You know, yes, the interstitial cystites, there's inflammation, neurogenic inflammation, sympathetic overactivities, those sensory neurons releasing all those substance P and neuropeptides and producing those inflammation. And then what will happen as a response? The vagus, the parasympathetic will become active because they feel the bladder there's something in it, and the bladder will contract by the vagus, by the parasympathetic neurons. So the big pharma say, oh, we just blocked the parasympathetic. When you block the parasympathetic, you're not really managing the neurogenic inflammation. In fact, parasympathetic and releasing acetylcholine is actually an anti-inflammatory neurotransmitter. It blocks and it inhibits those white blood cells, opposite to the noradrenaline when they act on the alpha-1 receptor. So what we did, we blocked the contraction, but also you block very important acetylcholine that's being released as anti-inflammatory. You actually aggravate the inflammation. And that's why Big Pharma failed to manage interstitial cystites. Why? Because their brain is being wired, or the Big Pharma thinking is all about key lock concept. Okay, so here's the problem. We have too much of contraction of the bladder. Let's just block it. And when they block the acetylcholine, you actually stop the acetylcholine, which has anti-inflammatory effect, and you aggravate the inflammation there. So how we can manage neurogenic inflammation, and I'm bringing this and I'm emphasizing on this because this is the case of Dr. Tom Yarima when he was bringing his case last I mean 2 weeks ago. Now we know it's neurogenic inflammation. Now he's managing with platelet lysates because those platelet lysates contain a lot of anti-inflammatory growth factors and antioxidants that may help to reduce the inflammation. And they have RNAs, I'm talking about RNA inside those platelets. So that gives you some sort of long-term expression of anti-inflammatory cytokines and anti-inflammatory enzymes. So another thing we talk about is methylene blue, buffering the redox, and it does have anti-inflammatory effect. And it's very good for neurogenic inflammation, methylene blue. Other thing that you can do is the ethanolamide, palmitoretanolamide. It's a form of synthetic CBD. CBD, it's good too. We're going to see that in the coming slides, how the CBD can help in managing neurogenic inflammation as well. So those are things that we recommend as integrative regenerative medicine managing neurogenic bladder. I don't really recommend much of acetylcholine inhibitors that the big pharma is doing because, as you see, they may aggravate the neurogenic inflammation here. So anyway, so what would happen when you have all this neurogenic inflammation? Definitely that will aggravate the allodynia, and then what would happen here? In the brain, there's two centers. One is called hate center, and one is called love center. The hate center is habenula, and the love center is called ventral tegmental area. This is the love center and hate center. So pain signals do activate the hate center, which is the habenula. And when you activate habenula, the habenula will inhibit the love center. And when you inhibit the love center, which is the ventral tegmental area, the ventral tegmental area will initiate, the love center, their job, if it gets stimulated, it will initiate a movement toward the stimulus. But if it gets inhibited, this ventral tegmental area, it initiates a movement of your body where you'll be avoiding the stimulus. In this case, because the pain signals stimulate the habenula inhibit the ventral tegmental area. So see it here, see the blue color here, it's inhibiting the ventral tegmental area here. Then the response is moving away from the stimulus. Okay. So and when I put the feather in the hand of these patients and they have allodynia, of course they will experience severe pain. Next, and they will be recorded in the brain in the hippocampus. So what would happen if the patient comes in the next visit and you just show them the feather, or he saw the feather in your hand, the patient will start crying and screaming and ask you, please don't, please be away, don't touch me. Why? Because that memory of the feather, of the allodynia, is being stored in the brain, and it activates automatically, and it stimulates the habenula, and the habenula gives you all these reactions of avoiding that stimulus. Okay, so, and what else? Okay, I did not even touch the patient in the next visit. He saw the feather in my hand, and he started crying. And he said, I'm feeling a lot of pain. I'm going to leave the office. I cannot take it. I didn't do anything. He just saw me, because he has a memory that's being stored in the hippocampus. And that memory in the hippocampus can be fired spontaneously when he sees the feather, and it can stimulate the habenula, of course, and give you all these reactions, dramatic reactions, and inhibit the tegmental area, which causes his body to avoid you and start saying, I'm leaving, I cannot take it, and he starts turning his head away from you and possibly leaving the room. And that's because he's inhibiting the ventral tegmental area, which initiate the movement that leads the body to move away from the stimulus, as you see it here. The other thing is that we can see is that what triggers the whole pain? Why is pain is getting so big, massive, just by seeing the feather? It's also that habenula, it does, see, you can see it here, the habenula, it does inhibit the descending analgesic neurons that is coming from the rostral ventrolateral medulla and from the lucus ceruleus. Those neurogenic, noradrenergic neurons and serotonergic neurons, they will be inhibited. These are descending analgesic pathway. They will be inhibited by the habenula. If you inhibit the brakes, what will happen to the pain? It become magnified, aggravated. So the patient, once he sees the feather, he feels intense pain, and he cannot even block it because it's the descending analgesic pathway is being inhibited by the habenula, as you see it in this slide here. Let me show you exactly. So the inhibition here is coming from, that is inhibiting the brakes, the descending analgesic pathway, right? And then you have less endorphin, and enkephalin is responsible to put this brake on those ascending pain signals. Okay, so one of the things that we will see is that due to this bombarding of the pain signals in the spinal cord, in the dorsal horn, we saw the hyperplastic changes, right? And the neuroplastic changes that happen, the progressive neuroplastic changes in the pain pathway that led to decrease of threshold, led to hypergesia, primary and secondary, and allodynia and phantom pain. We also see the same neuroplastic changes happen to the amygdala. Think about that. The amygdala also, you would have new dendrites, new connections, lowering the threshold of firing to the point that this amygdala can fire spontaneously without any external stimulus. What would happen if the amygdala starting firing spontaneously and activating all the memory of the experience of the pain, all the events of the pain? Then we have something that's called post-traumatic distress syndrome. Have you heard about it? See that? You see that circle here? And this is, we call it, see that one here? That's the post-traumatic stress syndrome. Okay, and so the patient will, without any notes, they will be experience the pain and all the events of the pain and all the trauma of the pain as it's occurring, and it's imaginary, but it's as it's occurring in front of them, and they start feeling the pain, all that stuff, and the burning, and they can even visualize from inside the brain the fire and all that stuff. And this is called what? Post-traumatic stress syndrome, or the stress syndrome, PSTD, right? And can the patient control it? No, they can't, because as you see here, the amygdala is sending an inhibitory signal to the prefrontal cortex, and the prefrontal cortex cannot really control it. So prefrontal cortex cannot put brake on it. So it happened without, it's unconscious. Patient cannot control prefrontal cortex. The reason because it's a massive pain signal, and because of this neuroplastic changes that's happening in the amygdala, generate powerful signal, pain signal that activate the memory and of the whole events and inhibit the prefrontal cortex, where the patient cannot control the sequence of the event or the triggering of the event. Okay, so what we do, how we manage centralized pain and the neurogenic inflammation. In pain management, we use opioid narcotics because it does give some good relief of the pain. It does open up the potassium channel, so opening up the activation of the mu receptor. Mu receptor will open up potassium channels, and when you open up potassium channels, you have hyperpolarization, analgesic, patient feels good. But what's the problem with opioids? Giving it short term is good, but if you start giving it long term, this opioid, those mu receptors also, they activate the NMDA receptor, the glutamate receptor, allowing the calcium to go in. And when the calcium goes in, calcium influx activates the oxygen, generate those free radicals, and those free radicals will express the structure functional of the dendrites, right, as you see it here. And so it will aggravate the neuroplastic changes in the amygdala and in the dorsal horn. So that's the problem that we have with opioid. In short term, it numbs the nerve by opening up potassium channels, but so the mu receptor, but also the mu receptors can also activate the NMDA receptor, open up calcium channel, and the calcium channel will lead to activation of NOx enzyme and release all those free radicals, causing those free radicals to be produced, and those free radicals can aggravate a progressive neuroplastic change, the formation of those dendrites and more connections, right, and lowering the synapses of the pain pathway, allowing the threshold of the pain pathway. And then what would happen also, those free radicals can irritate the glia neurons and produce neurogliosis, and neurogliosis, neuroinflammation, the spinal cord, and also in the amygdala. Same thing that happened in the dorsal horn, happened in the amygdala. It will lead to what? Release more free radicals. Those free radicals can lead to regressive neuroplastic changes of the encapsulogenic neuron, which is the interneuron that inhibits the pain signal, as you see it here. So it makes things worse, right? It leads to what eventually to also those free radicals can cause desensitization of the neuroreceptors. So when you give them opioid, it's not working anymore because those receptors are inactivated by the free radical, by oxidation. And the patients will be seeking more drugs to numb that pain that's being generated by the inflammation. Okay, so you start giving them more drugs, and then I will hyperonize the neuron. Yes, gives you some analgesic for short term, but it will aggravate the inflammation, the free radicals, the neuroplastic changes. It will lead to progressive neuroplastic changes in the pain pathway and regressive neuroplastic changes in the analgesic pathway of the neurons. That's in the dorsal horn. The same thing is happening in dorsal horn, it's happening in the amygdala. So this will aggravate the pain, right? And they need more, and leads to addiction, and need more of narcotics. And that's the problem that we have with opioid. So what it will be alternative to opioid? I think CBD does the same. They open up, they activate the CBD receptors, as you see it here. And the CBD receptors and the mu receptor, they have a common thing. They open up potassium channel, and that leads to numbing of the neurons, so hyperpolarization, analgesic effect. This is good. But CBD inhibit the NMDA receptors. That's the good thing about CBD. So it has antioxidant effect. It opposes the stimulation of NMDA receptor. Did you see that green here? Let's go here. That's inhibition. What are the things that CBD does? So here, it does numb the nerve, but it inhibits the NMDA receptor, so it has antioxidant effect. Opioids, it numb the nerve, right, by opening potassium channels, same thing like CBD, but it's a pro-oxidant because they open up NMDA receptor, which activate the NOx, generate the free radicals, and aggravate the neuroplastic changes. Okay, what are the things that does? CBD, there are CBD receptors in the glial neurons, so yes, it does have an inhibitory effect on the glial neuron directly, but also they inhibit the NOx enzyme and COX enzyme, so it has an anti-inflammatory effect, which is something good. Okay, what are the things that does the CBD? Of course, the CBD, if they decrease the free radicals, it has antioxidant effect. That's good. That will open up the receptors, right, of the mu receptors, and that's what we need, right? It will increase opioid receptor sensitization, and we can manage addiction, and we can start weaning patients from narcotic by using CBD, as you see it here. Okay, what are the things we can use to manage central pain and neurogenic inflammation besides CBD that we're using? We're using also tricyclic antidepressant, serotonin reuptake inhibitors. Why? Because that will activate, do you remember the descending analgesic pathway? They are serotoninergic and noradrenergic, which will activate the capinerogenic neuron, interneurons. So this will help to increase endorphins, and this will lead to, as you see it here, it will lead to putting a brake on the pain signals, right? So activating the analgesic pathway, the tricyclic antidepressant, serotonin reuptake inhibitor. GABA, ketamine, how they work. They block the NMDA receptors. That's a good thing, right? So there's no more calcium channel influx and no more of those free radicals and neuroplastic changes. So I can give them GABA and ketamine. Those are big pharma products. What are the things that you can use from supplement side? Resveratrol works the same like GABA. Taurine, I think, and another thing that works like vitamin B12. Yeah, I think they can work the same. CBD, you can use palmitoyl ethanolamide as alternative to CBD. Okay, so some patients, we give them steroids. Yeah, problem with steroids, you know the problem with steroids, right? It leads to atrophy of the bone and muscles and all the complicated hypertension, diabetes, secondaries. Really, you cannot give the steroid for long term, but short term is fine to decrease inflammation by blocking the COX and LOX enzyme. B12 does work by inhibiting NMDA receptors, same like GABA. Curcumin does stimulate the expression of antioxidant enzyme, so that's good epigenetically. But also they can scavenge the free radicals directly. So that, and also they block the COX and LOX enzyme, like anti-inflammatory drugs and steroids. Alpha-lipoic acid will also, it's good because it does, there are thiols, like cysteine. I think it's good to scavenge the free radicals with alpha-lipoic acids. What are the things scavenging the free radicals? Methylene blue is the best in scavenging the free radicals. I would use methylene blue, alpha-lipoic acid, cysteine, glutathione. All those are thiols. Will help. Other thing, we can do exosomes. Whether those exosomes are derived from mesenchymal stem cells from the follicle or derived from the platelet, related derived exosome, which is more accessible. And you can inhale it, intranasal, right? Those exosomes, and they can reach into the brain. You want to IV the exosome derived from platelets, that's fine. Some patients, you know, you can also IV the exosomes from the bone marrow stem cells or fat stem cells. I prefer the platelets derived exosomes because it's more compliant with regulatories. So exosome because they're very rich with RNAs that express antioxidant and anti-inflammatory cytokines. Okay, great. Now, what's the problem with all the big pharma products? Problem with all big pharma products that we talked about, they're not compliance with redox metabolism. They're not in compliance with mitochondria. Most of the big pharma products that's being produced by man-made, they did not check whether it affects the mitochondria or not. Most of them they do, and they inhibit the mitochondria, leading to mitochondrial dysfunction. when you have mitochondrial dysfunction, then the mitochondria will start leaking those free radicals and cause oxidative stress. So that's why gabapentin, ketamine, all those drugs, they are good for short term, but for long term, because of interfering with the metabolism of the redox and the mitochondria modes of mitochondrial dysfunction generating free radical, causing oxidative stress, it may aggravate the neuroplastic changes of the brain. And that's the reason why those drugs are not working, it stopped working. And you need more because of the addiction, because oxidation of the receptors will become, they become insensitive, right? Receptors of GABA, and so that's the problem that we have with big pharma products, is that it definitely interfere with mitochondrial dysfunction, producing oxidative stress oxidize those receptors and make them insensitive to those drugs. So you need more of them. So you end up with addiction, and also you end up with the side effects that's caused by the imbalance of the nitric redox and mitochondrial dysfunction. Okay, so I think we're going to continue next week because it's too long. I'm going to talk about drug addiction and managing drug addiction, and next Thursday. I think we can have a break or QA, and if you have any questions, please ask, and I will be unmuting the people. So Tom, are you there? Tom? People are sleeping here. Can you hear me, guys? Tom, are you there?
I'm here.
Okay.
Well, I mean, this is Dr. Joseph.
Okay, Dr. Joseph, do you have any questions?
Too many questions.
Okay.
I have to ponder and learn, and I got to put some time into this.
Okay, because you have a case of complex regional pain syndrome. So I need you to present that case in more detail. You presented before, but I need you to add more to the pathophysiology and the mechanism of treatment, and present it to us with more extensive, so that the people will understand that complex regional pain syndrome cannot be treated. As I heard from one of the doctor before, they say, well, you know what, just use what he said, DMSO, and for 3 days, the patient will feel good. That's not reality, because you saw the pathophysiology here. There's hard wiring. There's neuroplastic changes. There is, that's hard wiring that needs to be restored back to normal. There's neurogenic inflammation. You know, yes, DMSO, it's antioxidant. It does help to scavenging the free radicals. It does help with complex regional pain syndrome, with a topical or IV it, but it will not manage the complex regional pain syndrome by one shot or by one drug. It takes multi-therapeutic approach. You need to do all those therapies that we talked about, and it takes time. It takes up to 6 months for those patients to be weaned from their narcotics and restore the neuroplasticity of the brain back to normal and manage those neurogenic inflammation. So don't expect to manage neurogenic inflammation, centralized pain in 2 to 3 days. And you may need to do also phototherapy, photobiomodulation, which will help also to buffer the redox as well. So light therapy is another option, biologics, exosomes, and supplements that we talked about in the slide. So any questions, Dr. Joseph?
Yeah, I guess just a practical question would be, I take it that PR, and by the way, I just want to add something. I just, there was a spinal surgeon that had mentioned the DSMO, and I'm just contributing here. I think he was also alluding to the fact that the DSMO would, in the case of somebody with the median nerve injury, which is really what I'm dealing with, the purpose of the DSMO, my understanding was to get rid of, help to soften up the scar tissue that may have developed over time around the nerve. But and I'm not. This is not me. I'm not trying to.
Well, possibly part of it, but other part of it.
I'm not. Yeah. I'm not trying. Yeah.
DMSO is not bad. You need to do it
from everything else. I would.
Right. I mean, it's part of the treatment, but it's not the whole treatment.
Okay.
Right.
Exactly, and that's what I was attempting to communicate.
Right.
But my other contribution is, so I take it that if we made PRP lysate and we used it or put it in a nasal, sort of a nasal, whatever you call them, a nasal canister, and then sprayed it intranasally, that we may get some absorption, because these are nanoparticles through the cribriform plate, and with some sort of penetration of the limbic system or the prefrontal cortex, such that we may be able to have the I would say the growth factor, the modulation, maybe the neuromodulation, and potentially sort of reverse the regression of neuroplasticity. Is that sort of the idea?
Yes. So we are scavenging the free radicals, and we are doing it in all different level with platelet lysates. Yeah, they're rich of thiols, but they're rich of RNAs that express antioxidants, enzymes, anti-inflammatory, and that cytokines, and that helps to kind of scavenging the free radicals at all levels. The free radicals that's in the cytoplasm, and also the epigenetically, it can alter it as well, because you're expressing the antioxidant enzyme, anti-inflammatory cytokines, so at the genetic level as well. So yes, platelet lysate or platelet-derived exosomes or umbilical derived exosomes, all of this can help as an anti-inflammatory to restore the neuroplastic changes of the brain by dumping those the free radicals, or restoring the nitrodux balance, which will restore the neuroplastic changes of the brain. But it's a process. So we also need to.
The other one is this. Sorry, go ahead. Sorry.
No. There's some voice. No, not me. Go ahead.
Okay. The other idea is in addition to the platelet lysate inhaled intranasal inhalation, was an intranasal red light, because I was going through some of the studies showing that rat study, actually, that they were showing that there is absorption. It's a different frequency. I don't know if intranasally, if they go higher, like into the 800s, and I'll go back and review that again. But that may also be a way to buffer the redox.
Right. So something that I already sent it to you in your package.
Cortex.
Right. Something I sent in your package, the watch that's connected to it has a little nasal thing that you put it, and the light is antioxidant. It does buffer the redox. So if you have a tissue that has oxidative stress and you shine red light, it helps to decrease it. And how the excited electrons that is being excited by the red light will be picked up by NAD and reduced to NADH, and that will lead to production of glutathione, reduced glutathione, which will scavenge the free radicals. So light does buffer the redox. If you expose it to oxidative tissue, oxidative stress tissue, or inflamed tissue, it dumps the free radicals, or the mitochondria, of course. But in healthy tissue, it actually increases the free radicals to the level that will lead to expression of the antioxidant enzymes and increase the antioxidant capacity at the epigenetic level. So this is how light works. It buffers the redox. If it's high, it drops it to physiological level that we need it, and if it's low, it brings it up and kickstart the expression of antioxidant enzyme. In this case, we have oxidative stress in the brain. We have too much of free radicals, so the light does dump the free radicals and buffer it. by exciting those electrons that will reduce the NAD, and the NAD will produce glutathione. So those patients, if you measure the reduced glutathione before and after the light therapy, you will see the increase, and that will scavenge the free radicals. Doing that in the long term, you need to have, it's not just one shot, but you need to do it at least maybe 1 month, 2 months, even 6 months, even 1 year of this treatment. Eventually, that will lead to restoration of the neuroplastic changes back to normal. Again, light therapy by itself is not enough. You need to do all this multi-therapeutic approaches, everything that we talked about, thiols, polyphenols, GABA, that's fine. You can give low dose if you want, ketamine, all those things, but it needs to be done in a very conservative way. Try to do more of the supplements versus the big pharma. Big pharma, you can start in the beginning, but then you start weaning it and increase more of biologics and supplements, because we know the big pharma does interfere the mitochondria and cause oxidative stress with long-term use, and then they become insensitive. So you can start doing it as a short term at the beginning, just to have put that dumping, because the big pharma does have very good rapid effect. But then you wean them and you do more of nutraceutical and biologics and light therapy all the way down. It may take 1 month, 2 months, 3 months, 6 months, maybe 1 year to manage neurogenic pain and centralized pain.
Okay, thank you, Dr. Halassa. I have a question, if you don't mind. So thank you very much for this very interesting presentation, actually. And it's coming really in line with the new literature that actually talking a lot about inflammation in the brain as a mechanism for the chronic pain. And now they are showing more and more evidence in the research that there is the glial cells in the brain, which actually act as a scavenger as well, but also can also produce inflammation in the brain. And specifically, there are research now in the fibromyalgia, just to kind of confirm what you were talking about, that fibromyalgia, there is actually a clear pathology on the brain level that is widespread, that's responsible for the chronic pain. In addition to the, a lot of literature now talk about the catastrophization as predisposition for central sensitization, and also the transition from acute pain into chronic pain. So I mean, like, if we look at acute pain as being an insult, an injury to the body, and the body has some time to heal it, and that's why the focus during the acute phase on managing the pain and treating it acutely and quickly and aggressively, so, and then the patient to return back quickly to their normal functions so that healing starts.
Oh, it's
sorry,
it's actually
Can you mute who's talking?
yeah.
Okay, sorry, Dr. Sam, there's somebody's Tom. Dr. Tom, can you help? Okay, go ahead.
Yeah. Okay. So I mean, like the aggressive treatment during the acute phase can prevent the chronicity, that can prevent the sensitization and the escalation into the chronic. For failure to return to function and normal life, and that's what leads to the chronicity. And then the literature finds actually has to do with the personality. So now they're talking about, like, if the patient has the catastrophization up front, that is a risk factor for the acute pain to transition into the chronic pain. So now comes the question that now that we know more about the mechanism and inflammation and what you mentioned PRP as a therapy, and you recommended taking like 500 cc's of platelets and then break it into lysate. Now, is it used as like an IV infusion? Is it ever used, this methodology, as an IV infusion, or is it only injection at the local levels?
Okay, so let's go
the
ahead.
Same thing for the same thing for the methylene blue. Is it ever used as an IV infusion if we try to target the brain, for example?
Right. So let's go ahead. When I didn't say 500 ml of platelets, 500 ml of blood. and then
Blood,
up to
yes.
500
I mean,
ml of
sorry,
blood.
that's what I mean.
Right.
And then you spin it
Up to
into
500
platelets.
ml of blood, and for many reasons, for detoxification, stimulation of bone marrow to release peripheral blood stem cells, and getting as much as growth factors from the platelets of the exosomes from the platelets. That's the reason. So it's dose dependent. Even the joints, when you inject them with more platelet exosomes, the more efficacy you can have in managing pain. Not the case with whole cells. With whole cells, there is a plateau. But for exosomes, I don't think there's a plateau because it will diffuse all over. It is small size, it gets into the blood, so you get all the benefit behind it. Now, the question is that whether we are using exosome-derived platelet IV, okay? They are being used intranasally for treating neurodegenerative diseases. They are being used by spraying it. There's publication for that, and I'll present it, I'll give it to you. They are being used as nebulizing it for lung fibrosis. In fact, they're using it for post-COVID-19 lung fibrosis, and there's clinical trials for that, okay? Because this is a new era, I did not see any article yet, I cannot give you an article, that you can inject it into the blood, those exosomes. But we know we can inject exosome derived from mesenchymal stem cells, from the umbilical. They're doing it IV. We can do it for bone marrow. We're actually doing bone marrow stem cells. So I don't see any problem of IVing exosomes of platelets because we already have exosomes of platelets free in the blood. And breaking the platelets, releasing their exosomes, injecting into the blood, I don't think there's any harm, but I don't have any articles to or publications, or I did not do it myself. What I have done, we did intranasal, we nebulize it, but I did not do the IV yet. But is it harm to do it? I don't think there's any harm. Same thing for bone marrow stem cells. We did break down the bone marrow stem cells and inject them to the IV. We did it with fat stem cells, either whole cells or exosome derived. Exosome derived is more better because those stem cells as whole cells, whether it's amniotic stem cells or from bone marrow stem cells, fat stem cells, when we inject it IV, it traps into the lung and the kidneys, and they don't go to the pathology. But the nanocytes is better, so they are doing it, are ready for all these things. My question will be to you: if the bone marrow, it's already in the body, in the bone marrow, and the pathology, let's say it's in the joint or in the heart. So what we are doing, we are just moving the growth factors from the bone marrow cells that's stored in the bone marrow into the pathology. That's what we're doing, right? Okay, but normally your bone marrow does release some of those peripheral stem cells to heal the pathology, but it's not enough. So what we're doing, we're just aggravating that pathway, that mechanism to do more. So we're taking the bone marrow and then we extract the stem cells from it, and then we inject it into the blood. Hopefully we'll get the pathology. We know we don't get much into pathology because they trap in the lung. So in exosome form of the bone marrow stem cells, I think we can get more into the pathology, into the heart, and get more benefit from behind it, especially when you add light therapy as a photoregenerative therapy. So what we're doing, we're just taking those bone marrow cells or stem cells, and we're opening them up, releasing the little package which contain those growth factors and RNAs, and injecting the blood with the hope that they will trap into the pathology and causing the healing. Same thing for platelets. Those platelets contain good growth factors inside them, but they don't get enough into the pathology, right? We know that when we have a cut or wound, the platelets go there and gives you the healing process. But if you have a joint arthritis or you have any pathology in the brain, those platelets, growth factors, they still inside the platelets. So what we're doing, we're just taking it, opening them up, and then injecting the body in a nano size with the hope that they will reach the pathology and cause the healing. But right now, it's being nebulized, inhale it. It's being injected into the joints. Yes, platelet lysate with very effective. It's being injected into tendons. That's all that's being done. All form, epidural, all of the, but the IV, I did not see any article for platelet-derived exosome yet, but I don't see any harm of doing it.
I think, yes, a formal study probably need to be designed to show like safety and efficacy
Yes. So
before
I
it
don't
can
really
be used.
promote it to do it IV right now. I would be promoting it to inject it into the joint, muscle, tendon, inhale it, epidural, all that forms because articles. But if somebody does it, I don't see any harm doing it, but it's good to have a study before we actually do it on the patients, because what I'm promoting to my affiliate is that they have to have published articles if they want to do something outside the box. So in case they are being argued with the regulatories, you can show them the evidence. Here's the evidence. This is what's happening. This is what's doing. This is the clinical trials. And the doctor do have the right to do something outside the box, especially if they have a signature with the patient, and especially if the doctors see it is safe and there's no side effects. And doctors are already doing platelet lysate injections and epidural joints and all that stuff. Any
How
other
about
questions? Right.
how about the methylene blue infusion? I mean, it's done right
But
now for
methylene
other
blue
medical
IV
reasons.
is being done
Yeah,
to manage methemoglobinemia,
right.
malaria, with FDA approved. It's an FDA approved. When we are doing it for neurodegenerative diseases, we're not doing it in that pharmaceutical dose, which is 1 milligram, 0.5 milligram per kg to 2 milligram per kg. That's big dose, like around 50 milligram. We're asking to start doing just 10 milligram daily for neurodegenerative diseases, low than even the pharmaceutical dose, just to make sure we're in the safe side. So 10 milligram daily, it will be enough. If you have cancer and you want to do photodynamic therapy, then you can go ahead with the pharmaceutical dose and you can go up to 50 to 30 to 100 milligram. I think that's okay, because now we're balancing the side effects with efficacy there, and this is cancer, so you need to have high dose of drug going to the cancer to produce photodynamic therapy. But for treating inflammation or preventing or anti-aging or neurodegenerative disease, 10 milligram daily orally will be enough. It will stain your urine in 6 hours, which means absorption is almost 99%.
Okay, thank you.
And you can do it IV, but for an anti-inflammatory effect, capsules will be enough. All right.
Okay, thank you.
Sure. Any other questions? Any other questions? Okay, so I have the people who wants to do ANS. Is Ken there? Ken, are you there?
Yes, I am.
Okay, so is she's ready?
Yes, 1 second. Thank you so much, everyone. Well, that was an amazing talk, everyone. Most of it was way over my head, though. So I'm just trying to confirm that our people are ready. One moment, please.
Okay, while you are making things ready for your ANS to the motor interior function test, which you can place it for free in the offices to monitor the efficacy of integrative regenerative medicine. The same thing we do when we are treating or managing hypertension. We give the antihypertensive drugs, but how we know that the hypertensive drugs works, we use a sphingomanometer manometer. Okay, so when you're doing your integrative therapies, whether you're doing microbiome, peptide, or exosomes, or stem cells, and you're treating systemic diseases, rheumatoid arthritis, or how you know, or anti-aging, how you know that your supplements, your biologics do work? Is by ANS. If you normalize the ANS, you normalize the endothelial function test, that's mean your sex hormone, your peptides, your exosomes, your light therapy is working, because we know that the endothelial tissue are very sensitive to free radicals, pathological free radicals, and all this integrative approach is to buffer the free radicals. And so if we able to measure the endothelial function ANS before starting with your sex hormone or peptide or whatever you're doing integratively, supplements, and then after 3 months we measure the endothelial ANS and we see it's being normalized, then that indication your sex hormone does affect on the body. That's mean you're all optimizing the body. And when you improve the endothelial function test, you are minimizing the risk of COVID-19 cytokine storm, because we know that patients with obesity, hypertension, diabetes, they have endothelial dysfunction. Endothelial dysfunction, stress endothelium means overexpression of ACE2 receptor, which is a fertile land of COVID-19. That's why most of the patients who die from COVID-19 with cytokine storm, they have endothelial dysfunction. That's a common denominator according to the publications. So when you do all your optimizing of the health to try to boost the innate immune system, because endothelial cells is part of the innate immune system, then I think the endothelial infection test will be your guide to know whether you're on the right direction in optimizing the health and minimizing the risk of COVID-19 complication. Because when you improve the endothelial cells function, the ACE2 receptor expression will drop. And then you minimize the risk of those COVID-19 from replicating in the endothelial cells, producing what we call endothelites, and all the complication of endothelites, which can affect all the organs of the body. So I think Ken is going to talk about the system, how he's going to place it. No upfront charge for the doctors. Is Christy available, or who's presenting? Let me know, Ken, if there's some. Otherwise, do you have any questions? Questions? Hopefully, all of you will be part of being pioneers and fellowship in this new movement of chronic disease management centers and chronic disease management specialists. I think labeling yourself as chronic disease management specialist is a trend of medicine. Labeling yourself as integrative regenerative doctors is being under the water by the regulatories. They treating those people as terrorists. I think we need to shift that and tell to those people we are managing chronic disease. We're a chronic disease specialist. We use mainstream medicine, as we discussed here. I did not exclude all the big pharma products, the opioid, the ketamine, the gabapentin. But we also use integrative regenerative medicine as well. Is it available? Ken, is she here?
Hi, Doc.
Okay.
So sorry. I'm trying to hook them up on the call. Would it be possible for them to jump on next week?
Okay, that's fine. They can jump next week. That's okay.
Thank you so much.
Yeah. So we can continue. Dr. Tom, do you have any questions? Tom, are you there? Dr. Tom?
Yes, I'm here. No, I think I'm good. And look forward to next week.
Okay. Anybody here has any questions about the program to join pioneership in this new field of medicine, chronic disease management? I have Dr. Tom is taking California. Dr. Joseph James is taking Illinois and Wisconsin. So if you are interested in becoming a pioneer and getting all the tools that you need to perform photodynamic therapy, photoregenerative therapy, nanomedicine using platelet lysates, which I'm working with the Sonicator company to customize Sonicator to break those platelets into nanovesicle and load them with drugs. You can also load them with drugs, and that's a big thing in our and managing all kinds of chronic disease, because nano delivered drugs, nano cancer drug, nano steroids, nano supplements is way more effective than naked therapies, because they tend to target into the pathology and they don't go everywhere. So you decrease the volume distribution, you change the pharmacokinetic in a favor of more efficacy of that drug that you injected to the body. And they can inhale it. When you can create those platelet lysate, they can inhale it, they can nebulize it, they can intranasal it, and you can load them with anything you want. So something we call nanomedicine that can be done in a clinical level. So if you have any questions, please ask the questions.
Dr. Hassan, can we have this service in Canada?
Yes. You will be representing, I don't have anybody yet in Canada. If you adapt the protocols, you join the fellowship program by getting the package of the products that you need, along with joining us every week discussing all this hard to treat cases, and you bring all your cases, and we will discuss it, and we will be perfecting the protocols. You will be certified as a fellowship with us. There is also another affiliated, which I'm founder of it, which is called Academy of Oxidative Disorders. You will get the CME from them as well. I'm the founder of that academy. But the fellowship program that we have is to appoint pioneers, centrists all over the world. We have some people in Australia who are interested. Bennett, I don't know if he's still here. We have some people in India, Pakistan, UK, Canada. If you're interested, then we can set you up. There's a package range from 10,000, 60,000, 120,000. You can start with 10,000, and then you start, you know, if you see yourself, you can manage cancer, you can go ahead with the 120,000, because there's fiber optic devices and there's ultrasound guided injections and other complicated training. And I have Dr. Tom and Dr. Joseph here. They will be helping me to train the doctors in your clinic. We go to your clinic, or you come to our clinics, and you can observe what we are doing, and then you replicate what we are doing, and then you do more. You add more to your skills. You know, we will be learning from you as well, and from your skills in perfecting those protocols. So this is a platform for doctors to for education, and also for brainstorming, perfecting the protocols that we're doing, and manage all this hard to treat cases, report the data so we can publish it together. Any other questions?
Do you have anyone in Massachusetts, Dr. Halasa?
Oh, good. Massachusetts, great. Are you an MD?
Yes.
Okay, so we don't have anybody in Massachusetts, and it would be nice if you want to represent us. We will equip you with all the tools. You'll be part of the family. You'll become a pioneer. And yes, we will have Dr. Joseph or Dr. Tom, me. We're going to help you with setting you up completely, and you'll be doing all this photodynamic therapy to treat all the hard to treat cancer, infection. I think I shared with you my YouTube, where we can manage all this antibiotic resistant infections, Lyme disease, fungus infection, anything, name it. I think we have the tools, and we have the education and knowledge to really tackle the chronic disease more effectively even than the big pharma. And once you start having something that is outside the box and breaking through and frontier, that will attract more patients to your clinic, more recognition, because I will be part of our program and our centers. And you know, I'm promoting our centers to almost 10,000 doctors every week. And then I have companies who also helping me. They are nutraceutical companies or ANS Pseudomotor, and they're inviting more doctors. So we have companies also helping us to promote you. The more you be promoted, the more you be recognized as a frontier, a pioneer in managing chronic disease. And with the title of chronic disease management specialist, it's more compliance with FDA regulation, because Johns Hopkins, they just opened a department for chronic disease management. So that's the trend of medicine. CDC, they open up a website. It's called Chronic Disease Prevention and Health Promotion. So that's the trend of medicine. When you label yourself integrative regenerative medicine, you'll be putting yourself on the red flag with the regulatories, because they think you're a snake oil. They think that you are dismissing everything you learn mainstream. You are discrediting anything mainstream, and you're doing only holistic. That's where the FDA, they get irritated, and that's why they suspend your license. But when you put yourself as a chronic disease management specialist, those FDA that are PhD, they don't know the difference. But they say, okay, you're a chronic disease management specialist, so you're doing the mainstream medicine. Yes, we're doing the mainstream medicine. We're still giving blood pressure medication. We're giving insulin, but we're doing supplements and biologics and energy to reduce the amount of those big pharma, because we know those big pharma interfere with the mitochondrial function. So they will not end up with the addiction where they need more of insulin and more of hypertension drugs. And eventually it will complicate the patient's conditions with all those drugs that interfere with the nitroredox balance and aggravate the underlying inflammation of the chronic diseases. So if we can use little of the big pharma and more of the supplements, I think we can definitely, or possibly we can help to improve the general health of the patients, and possibly wean them completely from the big pharma. That's possible, especially if you have a diabetic type 2, they're obese, and you did all the integrative management and reduced his weight, and you did all this, possibly he doesn't need insulin anymore. So there is possibility that the patients can be weaned from the big pharma, but we don't wean them like this. We have to go through making sure that, you know, his blood sugar is being controlled, his cholesterol is being controlled, and we can wean the mainstream medicine and possibly they become free of drugs. If not, they at least even changing it from high dose to low dose, or weaning patients from narcotics. All of this is an accomplishment in medicine.
Mm-hmm. In September, I participated in an NIH HEAL conference, HEAL, which was all about fascia. And it was more, I mean, obviously pain is in the brain and isn't really always at the distal location, and it spreads through the fasciatomes, you know, through all of these tissue. But the HEAL conference was all about pain and was all about fascia, and came from a little different angle. I think this was really brilliant and well taught, easily understood, and a lot more comprehensive. And I'm sure it could be integrated with some of the fascia work.
No, I am with fascia work. Fascia, because here's the thing about the fascia. Fascia is the media where you have toxins and you have nutrition that goes between the blood and lymphatics and the cells. And if the fascia is hard and the viscosity is high and the diffusion is being embedded or hindered,
impaired,
then you need to open up the fascia to recycle the waste, and increasing the cycle of the waste and increasing the oxygen, etc., and the diffusion of the nutrition and the oxygen to the tissue. So massaging, even light therapy itself, sonication, there is very good sonicators, ultrasonic massage, that helps to break the fascia, turn those gel into more liquid, and speed the process of the diffusion of the toxins and recycle them and get rid from them. And so I am with fascia release as a management of pain, but of course, as we say, this pain is a multi-factor. You cannot manage pain with one option, or it's a multi-therapeutic approach. You need to you need to screen all the free radical generators. And yes, if you have a fascia that's thick and the diffusion is being hindered, you are accumulating the toxins, which is a free radical generator, and that will aggravate the whole underlying chronic conditions. So screening all the free radical generators that is coming from either from the fascia, or it's coming from the leaky gut syndrome, or it's coming from the toxins, or it's coming from hidden infection, Lyme disease, or it's coming from abnormal drug metabolism, or it's coming from abnormal malabsorption of food and nutrition and drugs, or abnormal metabolism of the nutrition, which we have genetic testing for all of that, or it's coming from exposure to energy, like Dr. Tom Yarima, the electromagnetic waves. Excessive electromagnetic wave can be opening up the calcium channels and generate and lead to calcium, lead to activation of NOx enzyme excessively, and free radicals and inflammation. All of those needs to be screened, and then you manage. It could be because of drugs the patient is taking can interfere with the mitochondrial function and leading to inflammation. So all of this needs to be screened, and then you manage in order to manage chronic disease, which including the pain. I think we learned today that a lot of chronic diseases can follow the same path, where it is local inflammation, peripheral inflammation, but it ascend up and become what centralized pain and neurogenic inflammation. And that's the reason most of the time we fail to manage those chronic disease, We managed to fail to manage rheumatoid arthritis because we failed to manage neurogenic inflammation and the centralized pain. We manage also asthma. Asthma could be complicated with neurogenic inflammation. Colitis, ulcerative colitis, irritable bowel syndrome, interstitial cystitis, migraine, psychosomatic diseases. We don't have any peripheral injury. It is coming from the brain. Psychologically, stress, it can manifest into a chronic disease. And we call psychosomatic, because when you have stress, you have too much of sympathetic overactivities, it can aggravate and cause inflammation in the periphery, lead to some psychosomatic diseases due to this norepinephrine overactivities, releasing those, leading to activation of NOx enzyme, free radicals, and activation of the white blood cells and inflammation. And that will aggravate any underlying condition, and it's because of the brain. So that's the reason when we manage centralized pain and neurogenic inflammation, we also need to put the factor of the cognitive therapy. Cognitive therapy does help to manage centralized pain. Do you remember? Did you notice that when we say that the prefrontal cortex can inhibit the amygdala? Well, the cognitive therapy works by activating the prefrontal cortex and enhancing the inhibitory effect of the prefrontal cortex over the amygdala and suppress the pain signals and the neuroplastic changes that's happening in the amygdala. So this is cognitive therapy is one of the ways to manage centralized pain and post-traumatic stress syndrome and all the chronic diseases that is being complicated by neurogenic inflammation, central pain. Any other questions? Yeah. Dr. Joseph, are you there? No. Tom, are you there?
Yes.
Okay.
Yes, I'm here.
Any question, Dr. Tom? You my left arm and right arm. So I want your participation. I want you to be introduced to those new doctors, the potentially new pioneers. You're going to help me to train those doctors, and then those doctors will become my pioneers, our pioneers, and then they're going to train doctors in their states as a fellowship program. So that's how we can really go some impact in the course of the medicine or advanced medicine by amplifying our work, by training our colleagues and be part of this network. And then we can grow from there and expand from there. So I recommend you all to invite your fellow doctors. If you become pioneers, you will be by partnership. That's mean you will be in the business, sharing with us revenue. So you would have horizontal revenue, training doctors, and also vertical revenue, treating patients. So think about it. And recognition, internationally and nationally. And then when you do the CME with Academy of Oxidative Disorder, you're getting your CME as well. So there's many good things to join us. Financially, you will be appreciated, and increasing the performance of your clinic. And then you can expand your spectrum of your patients, especially with this COVID-19 or post-COVID-19 arena. Medicine is being changed. You really need to think outside the box and think about managing chronic disease regardless of your specialties. See, if you are a neurologist and you have a patient with Alzheimer, you will say, I'm going to manage Alzheimer just by giving acetylcholine esterase inhibitor and increasing acetylcholine bioavailability. That's fine. That's a neurologist. What about other things to slow the degeneration of the neurons, of the acetylcholinergic neurons? No, that's not what we do. We only do this drug and you go home. Okay. As chronic disease management specialist, you will continue giving acetylcholine esterase inhibitor, but also you'll be thinking, what caused the decrease in acetylcholine neurotransmitter production? It's because of degeneration of the acetylcholinergic neuron. Oh, can we slow the degeneration of acetylcholinergic neuron? What makes it to degenerate? It's because of nitric redox imbalance, too much of free radicals, inducing apoptosis, and regressive neuroplastic changes in the brain. So what we would do, we start doing all this creative approach, managing if the patient has leaky gut syndrome, that will aggravate Alzheimer. Let's manage that. Is sex hormone? Let's go ahead and manage that because that will increase the antioxidant capacity of those neurons, scavenging the free radicals, and help to slow the progression of the new generation of the neurons. Check with the malabsorption, check with the nutrition metabolism, and you start screening all those free radical generators, and the ultimate goal is to decrease the degeneration of that neuron. You're going to do platelet lysate, and there's articles to support that intranasally. That may help to increase antioxidant capacity of those neurons, slowing the degeneration of the neuron and keeping the acetylcholine production. So this is you as a chronic disease management specialist versus a neurologist. But if you have a neurologist and he become a chronic disease management specialist as well, that's good. Then he can really manage that Alzheimer more effectively, giving them methylene blue. There's big pharma start doing that, giving methylene blue to treat Alzheimer disease, giving also cat claws, coffee bean extract, curcumin, ECGC, name it, sex hormones. If it takes to do peptides, you do peptides. Whatever it takes to scavenge the free radicals, slow the degeneration, that's part of you as a chronic disease management specialist, but it does not mean that you're going to stop them from giving acetylcholine stress inhibitor, but you can start weaning it once you see the patient is improving. Or you will prevent that drug from being increased, the need of it, because you're slowing the neurodegeneration. That's accomplished. Any other questions?
I'd like to thank everyone's attendance. This is Dr. Tommy Rima from Santa Cruz, California. And I appreciate you all putting into the chat your where you're located, what city and country. We have quite an international collection of individuals this evening. I've always enjoyed interfacing with doctors internationally. And what I find is that when we are dialoguing internationally, there's a lot more focus on fundamental physiology of healing rather than on big pharma-based solutions. And whether we're practicing primarily in an allopathic model or a truly integrative model, those of us that are in an integrative model, we're looking for good science, good protocols, good collegiality, case reports, open discussions of how we might do some things better. And I think that these weekly Zooms have, in my experience, been exactly that. They've been an opportunity for me to present my difficult cases, to get good feedback, to get good ideas and good tools that I could apply in my general practice that would not be costly, that are feasible, and that I could execute alongside either herbal therapies, nutraceutical therapies, detoxification therapies, or pharmaceutical therapies to increase the effectiveness of my results. So I look forward to further dialoguing with each of you, and I hope you can join us again next week.
All right, thank you very much, everybody, and hopefully we'll see you next Thursday.
Good night.
Good night. Thank you.
Thanks. Thanks for the good talk. Thank you.
Anytime.
Fantastic.
Thank you.
Thank you.